How many of you out there have a patient right now who has an ACL tear, who you're dealing with, or have had one recently? So, pretty many. Now, before I start, I wanted to kind of start out with an example. Say you have a young patient, 23-year-old, who injures his knee at work. It's witnessed. Goes to see the doctor. Doctor diagnoses an ACL tear, gets an MRI, confirms the diagnosis. Doctor recommends a couple weeks of preoperative therapy, gets approved. Patient goes through 2 weeks of preoperative physical therapy, then undergoes surgery. The doctor comes back, talks to you after surgery and says, surgery went fine, completely uncomplicated in a 23-year-old, but it's going to take him 12 months to 18 months to get back to work. There's no light duty available, and it could take up to 3 years. So what are you going to do in that situation? IME. You're going to schedule an IME before the first postoperative visit. You're going to take, you're going to call the adjuster, you're going to call the employer. Well, that situation is a real situation, and you all read about it here in the paper not too long ago because that was Derrick Rose. And so, Derrick Rose underwent an ACL reconstruction, and Dr. Cole, who I know, Dr. Cole and I both trained in New York and both did the same fellowship at Pittsburgh. And Dr. Cole said that he would take 12 to 18 months, even up to 3 years, to get back to where he was. And there's no question it was a work comp injury. Millions of people saw it. It was, he had no pre-existing condition. He was playing fine before that. Causality is not an issue. So the question is, you know, what happened there? Why is it going to take him 12 to 18 months? And how do we tell our 250-pound city laborer that it, you know, when he asks us how come Derrick Rose is going to take a year to 18 months to come back and you want me back, you know, 4 months, so how can we answer that? So the question is, did Derrick Rose kind of set a new standard for rehab for ACL, which is going to cost everybody a lot more money, or kind of, you know, what exactly is going on? And if you look at the AMA guidelines for ability to return to work, Derrick Rose should be back in 4 to 5 months. And if he's not, we shouldn't pay him, right? We should cut him off. So that's a question. I hope to answer some of those questions during this talk. And I kind of want to make this a little bit informal. So if there are any questions during the talk, please go ahead and ask. We won't wait till the end because things will come up during the talk. And the purpose of this talk is to give you a little bit of information that you can use when you talk to patients, talk to adjusters, talk to employers, talk to other nurses, so that you have just a little bit more information and a little bit more understanding of what we as physicians go through when we decide whether or not a patient needs an ACL reconstruction, and then kind of the decision process and as to how exactly to do it and how to rehab that patient. So I was going to go over clinical experience, a little bit of ACL overview, anatomy, ACL function, mechanism of injury, diagnosis, treatment, complications, key to success, and cost reduction. So at the end, we'll talk about maybe some ways that you can reduce the cost of a patient with an ACL reconstruction. Briefly, my training, I was a resident at the New York Orthopedic Hospital at Columbia University, which I was fortunate enough to be there because they have a very excellent, outstanding shoulder program. So I trained with some of the best shoulder surgeons in the world, and a couple of the physicians in the area, Guido Mara at Loyola and Greg Nicholson, trained there for their fellowship in shoulder. So I felt training there. I was very fortunate to have good training in shoulder, and then from there I went to the University of Pittsburgh sports medicine, where I received valuable training in my knee with Dr. Freddie Fu, who's one of the most famous ACL surgeons. I'm currently in a private practice. I pretty much specialize in knee and shoulders. I perform about 100 ACL reconstructions a year, both on acute, chronic, and revision cases. Throughout the country, there's probably 75,000 to 125,000 reconstructions performed a year. 85 to 90% are successful, and we'll talk about that in a little bit. But 10 to 15% fail, and some fail early, some fail late. But our goal as surgeons is to restore not only the pre-injury level activity, so we want to get the patients back to what they were doing before, whether it be work or recreational activities, but we also want to protect their cartilage and their meniscus from further damage that can cause arthritis in the future. So I wanted to just take a minute and go over some of the ACL anatomy. Most of you may or may not be familiar with this. The ACL has a tibial attachment and a femoral attachment. I'm going to get my own pointer here. I'm going to step out here for 1 second. So, can anybody hear me? There's a tibial attachment. So the ACL attaches to the tibia and it attaches to the femur, and it goes from medial to lateral, and it goes from the front to the back. And more recently, has anybody ever heard of double bundle reconstructions? You will. You will. More recently, there have been a lot of studies to show that the ACL isn't just one ligament. It's actually two ligaments. There's actually two portions to it, an anterior medial bundle and a posterior lateral bundle. And these bundles kind of act somewhat differently. And so some people have now been trying to reconstruct both bundles separately, and it's called a double bundle reconstruction. Some people call it double trouble because it's twice the surgery. But if you haven't heard about it, you will. Now, what is the function of the ACL? The ACL prevents the tibia or the shin bone from moving forward on the thigh bone. So I have a model here. So what the ACL basically does is keeps the shin bone from moving forward on the thigh bone. And when that happens, the patient experiences what we call symptomatic instability. They feel like their knee is giving out on them. But another function of the ACL is to prevent rotation. And if you see here, the ACL kind of goes off to the side, and what that does is it prevents the knee from spinning or rotating. If the ACL was actually straight up and down like the axis of a top, the knee would spin pretty easily. But because it's a little bit over to the side here, it also prevents rotation. And that's why sometimes when you rotate your knee, that's how you tear it, because the ACL is trying to prevent that rotation. So one of the functions is to prevent rotation. Another is to prevent varus or valgus movement, which is basically the knee going sideways this way or that way. So the mechanism of injury, it's usually a non-contact injury. You do not have to get hit, or it doesn't have to be a big injury to tear your ACL. Often it can be a hyperextension injury where somebody comes down and their knee kind of hyperextends. It can also be a twisting injury where there's a rapid change of direction, and not too often it's a direct blow like that. But most often it's going to be a twisting or a hyperextension type injury, which is important when you're going to make the diagnosis of an ACL tear. You want to know the history. How did this person injure their ACL? If you have a person in your office, they injured their ACL, they said, the desk drawer hit them when they were sitting at their desk, that doesn't fly. That's not a legitimate mechanism. But usually by the history and physical exam alone, you can figure out that they have an ACL tear. And often by the history alone, you don't even have to examine the patient. Now, the history, the main thing the person who has an acute ACL injury, they're going to complain of a pop, or they're going to say, my knee popped. And that's almost 100% of the time they're going to say that. They're going to have immediate onset of pain, and they're going to have immediate swelling. If they didn't have pain, they didn't have pop, they didn't have swelling, you got to think maybe this is more of a chronic injury, or maybe it's not an ACL. You always have to ask, did they have a previous injury? They could tell you, I was 18, I hurt my knee playing football, I was fine until I was 30, and then I kind of twisted and my knee gave out. It didn't swell, there was no pop. So that may be a chronic injury that they just exacerbated. Most of the time they're going to complain about instability or their knee giving out, but instability in and of itself does not mean an ACL tear. Instability can have a whole variety of causes. And it may not be painful after the initial injury. Sure, the initial injury is painful, there's no question, but after the swelling goes down, after they get their motion back, there may not be much pain there, and they may be able to function walking normally. That's one question patients always ask me all the time. If I tore my ACL, why can't I walk? Well, you can walk fine, but they just can't play sports or pivot or twist. So when you think about causality, you always have to think about what was the mechanism of injury, and does the mechanism of injury make sense? ACL tears, again, usually do not hurt. So if the patient comes in and says, my knee hurts, fixing their ACL is not going to solve their pain unless they have another problem. So if they just come in complaining of pain, then they may have a meniscal tear, they may have cartilage damage, they may have something else like the guy who put a nail gun through his knee, but it's usually not going to be just an ACL tear. So what are we going to see on examination? On examination, you look for swelling, especially in the acute phase. It's going to swell. It's going to stay swollen for a week or two. they're usually going to get muscular atrophy, and that happens pretty quickly. That's going to happen within a few days to a week. They're going to have a positive Lockman examination. They're going to have a positive anterior drawer, and they may have a positive pivot shift, but a pivot shift is very difficult to perform in the office because patients aren't usually relaxed. Are you familiar with the Lockman and the anterior drawer? For those who aren't, the Lockman is an exam where you bend the knee slightly, about 20 degrees, you stabilize the femur, and what you do is you pull up on the shin bone. So what you're doing is you're bending the knee slightly, and you're pulling up, and you should see increased translation. You should see movement. And you always want to compare it to the other side, because if you can see increased movement on one side, then you compare it to the other side, and unless they have bilateral ACL tears, there should be more movement on that one side. That is by far the most sensitive test. That test, in somebody who sees a lot of ACLs, that test is almost 100%. So that's much more sensitive than an MRI. So if you have a history of somebody who twists their knee, they have a pop, they have immediate swelling, and they have a Lockman, you have an ACL tear. It's 100%. The question is, do you have anything else going on? An anterior drawer is a little bit different. An anterior drawer is where you bend your knee to 90 degrees and you pull forward, and you can get similar translation. However, sometimes meniscal tears will give you a little bit more translation, so it's not as specific for an ACL tear. Now, I did have, unfortunately, this is one of the technical things we were trying to work on, and I had a video of a Lockman that we were performing in the OR with the patient asleep, and it won't play, unfortunately, and I also have a anterior drawer, but basically what we're doing is we're just pulling. If this video played, you would see the knee just moving forward. So during the examination, the Lockman and anterior drawer are pretty much for the ACL, but there can be other ligaments involved. You can have the posterior cruciate ligament, you can have the medial collateral ligament, lateral collateral ligament, you can have the posterior lateral corner. So at the time of the examination, you want to check all the ligaments, and sometimes it's really difficult because the patients are very tender, they're very swollen, they're very painful. You can do a McMurray's test, which is a test where you kind of twist the knee, you bend it and twist it, and as long as they have enough motion and they're comfortable, you can bend that, and that's a pretty good test for a meniscal tear. And you also, during your examination, you also want to document the patient's BMI, because if you have somebody with a BMI in the 50s and 60s, you got to think twice if you really want to do an ACL reconstruction and what their quality of life is before and after surgery. You also want to look at their gait, how they're walking, and their knee alignment. And you can tell a lot by how they're walking and their knee alignment, whether they have a pre-existing kind of degenerative condition. X-rays, even if patient comes in with an MRI, you always want to get X-rays. And the X-rays we get are always standing weight-bearing X-rays. So oftentimes, a patient will come in from the emergency room, they'll have X-rays that aren't weight-bearing, that aren't standing X-rays, and we go ahead and take standing weight-bearing X-rays. And it may seem like a waste of money, and you're wondering why if they had X-rays. Well, we know they don't have a fracture, but weight-bearing X-rays are going to show us if there's any arthritis in the joint. It's going to show joint space narrowing. It's also going to show notch narrowing. And what happens in the intercondylar notch, if you have an old ACL tear, you're going to see narrowing in the intercondylar notch. And you can see osteophytes or spur formation there, and that's going to give you an indication that this was an old injury. And you're also going to look at the bony alignment. You're also going to look for loose bodies and just generalized arthritis. But the views we normally get are a standing AP view, a PA 45-degree weight-bearing view, and a lateral and a patellar view. And most patients now do get an MRI. Like I said, if you have a pretty straightforward history of a patient who has a pop, a twisting injury, immediate swelling, has a positive Lockman, you don't really need an MRI. Although to get work comp approval, you often do need an MRI. But they may not always be positive. It all depends on the radiologist. Sometimes you'll get an MRI and it'll look nice and clean. And here's the AP view. Here's the side view, and this is a normal ACL. But sometimes there'll be a little swelling up here near the femoral attachment, and the radiologist will read it as intact ACL. I had one of these last week where they read it as an intact ACL. ACL's fine. And you examine them, and they're very loose. And what happens is they've torn it off up here, but the ACL has kind of scarred back down or kind of laid back down right onto the place where it should be, but it's not really attached. So when you examine the patient, they're loose. So then what happens is you have a radiologist reports this as intact ACL, you examine the patient, they have a torn ACL, and then you try to submit it for work comp approval, and then you run into a roadblock. So the MRI can be good, but it can be bad. In fact, I had 50 patients that I presented once that had normal MRIs, normal meaning that they were read by the radiologist as normal, but they all had torn ACLs when we operated on them. But the MRI is useful for looking at meniscal, cartilage injuries, other ligaments, looking for partial tears. And also, every MRI, the surgeon should review it, not just the radiologist, because sometimes the surgeon will know exactly what they're looking for, and they'll pinpoint things a little bit more than the radiologist can. Any questions about diagnosis, ACL? Nope. Okay. We'll go on to treatment. Treatment for the ACL can go anywhere from applying an ACE bandage and sending them out the door to a complete reconstruction, and anything in between. So the treatment is going to depend on the expectations of the patient. What was that patient doing before that they were injured? What are their expectations for afterwards? And depending on those expectations, you'll decide whether or not surgical or non-surgical treatment is indicated. And the patient may have different expectations from the doctor, from the nurses, from the therapists, from the employer. As the patient, how many times you hear, I'm not going back to work until I'm 100% and I have no pain? Well, that's not going to happen, because they want to be just like they were before. Well, that's not going to happen, or if it is, it's going to be a long time. The employer, on the other hand, wants them to come back as soon as possible, so they want them back in 2 days. The surgeon wants them to return to their pre-injury level as soon as possible without risking doing more damage to their knee, without damaging the articular cartilage or the meniscus. So there's a communication, and there should be an open line of communication kind of between the patient, the nurses, the therapists, the employer, and the surgeon as to what are realistic expectations. And that conversation should be had up front with the patient before you ever proceed with any type of surgery. And you need to tell them you will not be pain-free for a long time, and you may not ever get to your previous level of activity. So if you think you're going to wait until you get there, it may not happen. So the non-surgical treatment is appropriate usually in anywhere from 1/3 to 2/3 of isolated ACL tears. Complete tears will not heal. They just absolutely no chance of healing. Non-surgical treatment is appropriate if they have no meniscal or cartilage injury, and it involves usually physical therapy, and we want them to have full motion. We want them to have no swelling, near normal strength, no symptomatic instability with either their activities of daily living or work. And usually with therapy, they can return within 2 to 8 weeks. Sometimes we'll use a brace, depending on their activity level. And even if they use a brace, even if they have no swelling and return and appear pretty normal, 10 to 25% will develop meniscal tears within 5 years. Now, the surgical treatment we usually reserve for symptomatic instability, because symptomatic instability or the patient's knee kind of giving out can lead to arthritis and can cause meniscal or articular cartilage damage. So we're looking for symptomatic meniscal or articular cartilage injury. That's one indication to perform surgery. Multiple ligament injuries is another, and a desire to return to high-level activity or in a patient whose knee would be at risk if they did not have an anterior cruciate ligament reconstruction. For example, a fireman who has to go up on a roof and has to rely on his knee. If you do not perform an ACL reconstruction, his knee gives out when he's up on a roof. That could be a problem. So you can have partial tears of the ACL, and this is a little bit where we get into the two-bundle approach. You can have just a partial tear where you just tear what's called the anterior medial bundle. And what happens with that is the knee will kind of slip forward because that one part of the anterior cruciate ligament keeps the knee from slipping forward. The second part, the posterior lateral bundle, is the one that keeps the knee from rotating. So sometimes patients will come in and their knee will be pretty stable, but they complain that they feel like their knee's given out. And You perform a pivot shift, which is a test where you rotate their knee, and it's very difficult to perform in the office because they won't relax. And their knee will twist. They'll have increased rotation of their knee, even though their translation or their forward back movement will be normal. So they can have partial tears and have symptomatic instability, and often the radiologist will read this as normal, so the patient is not crazy. A complete tear, so let's say they have a complete tear of the anterior cruciate ligament and you're going to perform surgery. Then the question is, what's the timing of the surgery? If you perform it in the acute setting, meaning when it just happened, then there's a risk of developing what's called arthrofibrosis. And arthrofibrosis is just developing abundant scar tissue in the knee. And the problem is, if you develop abundant scar tissue, then you spend all your rehab time trying to get the motion back, and you cannot progress with your therapy. So therefore, if you do have an acute injury, we always wait until they have full motion, they have good quadriceps control, which usually takes 3 weeks, but sometimes it's much shorter, sometimes it's much longer. It can take 6 weeks, it can take 8 weeks. And often we can't put a time frame on that, and somebody will ask, well, when are you going to do surgery? Well, we'll do surgery when the patient's ready. That means they've demonstrated they have full motion and they have some kind of quadriceps control. And the reason we want them to have full motion is we want to avoid the complication of arthrofibrosis, which is just going to prolong their recovery. And spending 2 or 3 weeks in therapy before the surgery can save you months afterwards trying to get the motion back. And it can also save you another surgery if they don't get their motion back and the scar tissue becomes too mature. And a repair rarely works. So if anybody says, I'm going to repair an ACL, or I'm going to try and sew it back together or sew it back to the thigh bone, it rarely works. And I don't know if any of you remember these thermal devices, Orthocentrix or any of those, where they used to shrink ACLs. Anybody remember that? They used to use it on shoulders, called thermal capsulorrhaphy, and it was basically an instrument that they found, and we used to apply it to everything. We used to see what it would work on, and it would shrink a partially torn ACL. The problem is it would disintegrate the remaining tissue, and it would usually lead to a high failure rate. So the only true way to fix an ACL is to reconstruct the ACL. You can't really repair it, you can't shrink it. Once it's completely torn, you have to actually take that portion out and replace it. So then the question is, what do you replace it with? What are your choices? You can either take a graft from the patient, which is called an autograft, and the options there are the bone, tendon, bone. You can take the hamstrings, and you can take either a double or quadruple hamstrings, or you can take a quadriceps tendon. Or you can take it from a donor, which is an allograft, or there are synthetics, but they don't work. And we'll talk about that in a minute. So the most common autograft, the most common taking it from the own patient, is the bone, tendon, bone. And what you're doing is you're taking a piece of the patella, a small piece of the patellar tendon, and you can only take about 1/3 of it, and then you're taking a small piece of bone off the tibia. And it's very strong. It's actually stronger initially than the normal ACL. It allows for something called rigid fixation, and this is a point that we'll talk about a little bit. But what rigid fixation is you have bone, tendon, and bone. And so when you put it in the knee, you're fixing it with screws, and we'll talk about that too. But you're basically fixing bone to bone, and you're holding it in with screws. So bone is healing to bone, which heals much, much quicker than bone healing to soft tissue or bone healing to tendons. So the rigid fixation, where you can actually put a screw in there and have bone healing to bone, allows this part right here, the bone to heal the bone, usually within about 6 to 8 weeks, which allows for a little bit quicker recovery, a little bit quicker rehab from the therapist's point of view. The downside of using a patellar tendon is you can get anterior knee pain. So anywhere from 5 to 52% of people who have a bone, tendon, bone get anterior knee pain, and this can be a problem if you have somebody who does a lot of ladders, a lot of stairs, kneels, anything like that. So those people will have difficulty kneeling. They can get some quad weakness. The advantage is it has kind of the lowest failure rate, and it's best for a young person who wants a quick return to his activity. So this is what was used on Derrick Rose. And the question is, you know, will he get anterior knee pain? If he gets anterior knee pain, it's going to be patellar tendonitis type pain, and can you play basketball with that? The advantage is it's the quickest healing, it has the lowest failure rate, and it's probably the strongest tissue out there. Now you can do a hamstring reconstruction, and the advantage of a hamstring is you're taking two of the hamstrings, and either you're doubling them over or you're just using a single layer of the hamstrings. And you get less anterior knee pain with a hamstring reconstruction, but you have weakness in the flexor of the knee. And what happens is if you're taking the hamstrings, so you're taking the hamstrings, and the hamstrings wrap around here, and what the hamstrings do is they kind of push the knee back, or they keep the knee back. So if you're removing two of the tendons that keep the knee pushing back, that allows less force to keep the knee back, so that has more of a tendency to the knee to move forward, which is what happens when you tear your ACL. Your knee moves forward. So the hamstrings, they do have a higher failure rate, and it's longer healing because you're healing, when you insert it, you're healing tendon to bone, not bone to bone, so it takes longer. Has a higher failure rate. You have to slow down the rehab. So if you have two patients, one had a patellar tendon, one has a hamstring, sometimes the hamstring patients feel better because you're not taking the piece from their kneecap, but you have to slow down their rehab because they heal slower. So not all ACLs can rehab at the same rate. And the other thing is, and I'll mention this a little bit later, is when you fix it, usually you're fixing it up here and down here. And when you were fixing the patellar tendon, you're usually fixing it here and fixing it here. So when you fix it closer together, there's less chance that it's going to stretch out. If you imagine a rubber band, you take a rubber band and you try and hold your fingers close together and you pull it, it doesn't stretch as much as if you have your hands farther apart. So if you pull your hands farther apart, it can stretch. So sometimes the hamstrings, if you fix them here and here, there's more of it to stretch, so it can tend to stretch out, so you'll have increased laxity. And then there's also the quadriceps tendon, which is a fairly new tendon that people have been using. It's not well studied. There's less anterior knee pain, but you can develop quad weakness. Now we'll talk about allografts for a second. Has anybody had experience with allografts? Their surgeons using allografts or talk to you about allografts at all? Not too many. Okay. Allograft is basically a donor tissue, and you have to know what donor bank you're using, because sometimes the donor bank, it can make a difference. And an allograft tissue has a small risk of transmitting disease, and what we're talking about is AIDS or hepatitis, and it's usually about 1 in 1.5 million. But there is an increased risk of infection, and there was a case, or several cases, in the Midwest probably about 10, 15 years ago, where they developed a fungal infection that wasn't detected, and young patients actually died from an allograft. So there is a risk of infection. It's slow healing. It can take up to 18 months for an allograft to completely incorporate. So it takes a long time to heal. And because of that, it's not recommended in patients under 40 years old, or it's not recommended for high demand patients. People feel better if they have an allograft because you're not taking their own tissue, so they feel like they can do things quicker. But the chances are that they can re-injure their knee because it just has not healed, it hasn't matured. So therefore, it has a high failure rate, especially in people under the age of 40. Allografts, you can consider those in laborers who need to be able to kneel. Like I said, it takes at least 18 months to heal. There's less postoperative pain. There is an increased cost to using an allograft. Usually patients can get their strength back, and sometimes the companies who provide the allografts will irradiate them to try to minimize the chance of transmitting a disease. The problem with when they irradiate them, so they x-ray them, the problem with that is it can weaken the allograft or change the allograft. So you have to know, the surgeon has to know whether it's irradiated or non-irradiated allograft too. Some of the allografts are the bone tendon patellar tendon bone, which we talked about. You can use hamstring allografts. You can use Achilles allografts. You can use tibial tendon allografts. You can use fascia lata allografts. The fascia lata, the tibial tendon, the Achilles tendon usually don't work so well. I mean, they work, but they tend to stretch out. They tend to have some more problems. Bone tendon bone, hamstrings are usually the most used allografts. There was a big push in the 1980s to use synthetic grafts, and in the 90s, all the surgeons ended up taking these things out because they put them in and it sounded like a good concept. You use a synthetic tissue, you put it in there, it takes the place of your own tissue. But the problem was it was too stiff. So what would happen is when the knee cycled 100,000 times, it would start breaking and start fraying, and they would get synovitis in their knee, and all of them failed. Now, there are some synthetic ligaments that are now under development, and they may solve some of the problems that they had, but right now there is no synthetic ligament out there. So what's the ideal graft? Unfortunately, the ideal graft does not exist. So an ideal graft would mimic the biologic and anatomic ACL properties. It would heal rapidly, it wouldn't hurt the patient, there would be low donor site morbidity, and it would be readily available. But unfortunately, there is no perfect graft. It's just a matter of which one fits that patient and which has the least amount of issues. So that's the graft. So once you've decided with the patient and the surgeon kind of which graft you want to choose, then another issue is where you place the tunnels. And if you have a patient with an ACL tear, if you haven't heard about this issue, you may, or you may notice it when the doctor's talking about it. There is a trend now to place the tunnels lower down here. So this is the tunnel in the femur where you're going to put the graft. And if you remember one of my first slides, the ACL was kind of on an angle. And the reason we want it on an angle is it prevents the rotation. So what happens is if you end up putting the graft too vertical or too much up and down, then the knee can rotate. It'll be stable front and back, but it will rotate. And so if the graft is too much in this direction, the knee is going to rotate just like on the axis of a top, and that's going to cause problems with cartilage, that's going to cause problems with the meniscus, and the patient is still going to feel like their knee buckles or gives out, but instead of going forward, it's going to twist sideways. So the trend now is to lower these tunnels and bring them more down here or in this area just to prevent that rotation. So there's a whole new concept of retrograde drilling or drilling through the medial portal. So you may hear some of these things, but the goal of that is just to bring the tunnel a little bit down lower and prevent that rotation from occurring. Now, what I mentioned earlier was the double bundle. So because there are actually two bundles, some surgeons are trying to recreate those two bundles, and what they're basically doing is two operations, one for each bundle. And a lot of attempts have been made, and basically they're calling them double trouble, because if you do, there's twice the potential risk, and even though theoretically it's a good idea, it hasn't been proven to be any better than a single bundle reconstruction. And it has a very, very high failure rate, 10 to 20% fail within the first few months, and it's a very slow rehab. So if any of your surgeons out there start talking about doing a double bundle, you have to ask them why they want to do a double bundle. So now you have the graft. You put the graft in, kind of how do you hold it? You can hold it in place. If you have a bone, tendon bone, you hold it with screws. And then there's two types of screws, titanium screws or metal screws or bio screws. And there's really no difference. The reason more people are using bio screws now is they don't show up on an x-ray. Usually within 2 years, they'll dissolve or turn into bone. And if you ever have to go back and do another surgery, there's nothing that you have to take out. For the soft tissue, for the hamstring reconstruction, it's basically what we talked about. When you fix it, you're fixing it up here and down here, and that can allow it to stretch a little bit, which makes increased laxity, and that can also cause what's called tunnel widening. You see where you place the ligament, the tunnels widen a little bit. Now what I wanted to do was give an example of an ACL reconstruction. I have a video, and we're going to go through first the arthroscopy, just a general arthroscopy, and you're going to see the ACL tear, you're going to see a medial and lateral meniscal tear. And then there'll be a little bit of a lateral meniscectomy, a medial meniscal repair, how we prepare the notch, which we're preparing the knee to put the ligament in. We're drilling the tunnel in the shin bone, we're drilling the tunnel in the thigh bone, and then we're passing the graft. And hopefully this will play. So this is our setup when we do it. We take the good leg and we put it in a leg holder. We take the leg we're operating on, and we put the good leg in a leg holder away from the patient so we have room, and we have to be able to flex the knee. And then we start by making the 3 small incisions, and we look inside with the arthroscope, and through one of the incisions we put the arthroscope, through one of the incisions we put a little cannula that inflates the knee and puts water in the knee, and through the other one we put the instruments that we use to do the reconstruction. This is an arthroscopy. This was probably a 32-year-old woman who hurt her knee at work, and what we're looking at here's the patella. This is the trochlear groove. Now we're coming down the side. This is the side of the knee. So here's the medial meniscus. Here's the medial femoral condyle, medial tibial plateau. So this looks beautiful. There's no arthritis here. There's no wear. Looks absolutely fine. So what I'm doing is I'm probing, and underneath the medial meniscus, there's a tear. You can see I'm pulling. That shouldn't pull out like that. So it's torn underneath the medial meniscus. The top part of the meniscus is fine. And the meniscus has a blood supply which allows you to repair tears that are back here, but tears that are closer to the edge here, there's no blood supply there. So those tears can't be repaired. Those have to be trimmed. And now what we're doing here is coming across, and this is the anterior cruciate ligament. You'll see it in just a second. And here's the tear. That's what's left of the ligament. And so all this is torn. That's a complete tear of the anterior cruciate ligament. It should be attached over up here. And then I'm just probing the anterior cruciate ligament here. And then we'll go over and look at the lateral meniscus, and there's actually 2 tears in the lateral meniscus. There's a tear here, which is a radial tear, and then there's a tear back here, which is a flap tear. And these tears cannot be repaired because they're away from the blood supply. So this is a tear that's what we call a flap tear, and this is a radial tear. This is like you took a scissors and just kind of cut it straight across like that. So this type of tear can't be repaired either. That just has to be trimmed. So this is the lateral. This is the lateral meniscus. This is the one that could not be repaired. So what we're doing is we're just trimming the edges, and we have a variety of biters that we use for this. So this is just like taking bites out of it. And these biters are only about 2 or 3 millimeters, so they're pretty small. So I know it looks brutal, but what we're doing is we're just kind of trimming. I know, it looks like a mouth, yeah. So we're just eating up the meniscus, and then we put a little shaver in there, and this shaver is only 3.5 millimeters. And so what we're doing is smoothing out the edges so it doesn't get caught anymore. So that's the lateral meniscus, and we did the same thing to the other part of the lateral meniscus. So we want to smooth it to have a nice edge there. Go back, and then this is the medial. See if I can get this one to play. Here we go. So this is the medial meniscus, and this one we could repair because the tear was far back, and if you had to take that piece out, you'd have to trim a large piece of that meniscus. So we can actually sew this one up because it's near the area where there's a blood supply, and as long as there's a blood supply there, we can get the meniscus to heal. So we can actually put stitches in there. And this is a device where we put one stitch in there, and it's got a little anchor on the back side of it, and then it has a loop, and we put another anchor in there. And so and then there'll be a suture, and this is what's called fiber wire suture. It's very strong, and it looks like a big knot of suture here. But when we actually pull it, it's like a slip knot. And what it'll do is it'll pull down and it'll push the torn piece back together to where it belongs, and it'll hold it in the correct position and allow it to heal back together. So that's after I pushed it, and then this is the loop that's left after you push it. And what you do is you have a device that just kind of trims that piece off. So this is one of the stitches in there. And some tears, it's very rare that a tear will only require one stitch. Most of the time you're going to put 2, 3, 4, 5 stitches in there. But this one just required one stitch. Now what we're doing, so we finished the medial meniscus, finished the lateral meniscus. Now we're cleaning out the old torn part of the ACL. It's called notch preparation or notchplasty. So we're just kind of cleaning out. This is the posterior cruciate ligament, and here's the anterior cruciate ligament. And we just kind of cleaned out what was left of the anterior cruciate ligament because none of that's any good. And then, go back here. What we do is we make a little bit more room in this area for the new ACL. So we want to put the new ACL in here, but we need a little bit more room. Often we don't need a little bit more room, but sometimes we do, and we do what's called a notchplasty. So what we're doing is we're removing just a little bit of bone off the side here so that there's enough room for to put in the new ACL. And so I'm using, this is a little chisel, and we're just removing literally about 2 millimeters of bone here. And again, I know this looks barbaric. And then we use a burr and kind of smooth out the area. And then this is the area that we've prepared to accept the new ACL. And here's the PCL. So here's the area where the new ACL is going to go, right in that area. And then we've done that, we want to drill our tunnels. So there's 2 tunnels we have to drill. One is in the shin bone right here, and one up here in the thigh bone. So we have this device that looks like a protractor that we put in, and it marks the exact point where we want the ACL to go. And what we do is then we drill a wire, and the wire will exit right here, and then we put a drill over the wire to make the tunnel that we're going to use to put the new ACL in. And the problem is you can only be about 2 or 3 millimeters off at most, and if you're more than 2 or 3 millimeters off, most likely it's going to fail. So you have very little room here for a mistake. So this is the device, and there's the pin that we drive up there, and it usually is going to come out right at the elbow of that device. And so now over this wire, we're going to drill, and that's the drill coming through. And you don't want to drill too far because then you're going to drill into this bone or you're going to hurt the posterior cruciate ligament. And so this is the tibial tunnel that we've created. And then what we do is we smooth out the edges of that tunnel so that the new graft that we put in there, we don't want it to be rubbing up against the tunnel because that could cause it to fail. And this is a little shaver. So we're getting all the soft tissue away from that tunnel. So that's our tibial tunnel. And then we have to do our femoral tunnel. And there are devices that you can use to aim where you want that tunnel to be. And again, we don't want it to be up here because then the knee can spin like the top we talked about. So you want it to be down here, and you can only be a couple millimeters off from the back of the wall in order for the reconstruction to work. So this is a device, it's an offset guide. So you put the tip all the way in the back of the knee, and then you bring a wire up, and that wire will be placed exactly where you want the graft to go. And then you remove the aimer, and then you drill over it. And here comes the drill. Just like you see at the hardware store. And it's got marks here so we know exactly how deep we're drilling. And then this is the tunnel we've created, and this looks like it's in a good position. Then we use this, what's called a dilator. It basically is compressing the bone, so it's pushing the bone, and it's making, it'll give us a nice tight fit for the new ligament that we're going to put in there. And the other thing is we're making sure that we can fully extend the knee, and there's enough room for the graft, because if there's not enough room for the graft and the patient tries to fully extend the knee, then the graft is going to hit the top part of that notch, and they'll never get full extension. So you can go on forever, but they'll never be able to get their knee perfectly straight. And then what we'll do is we pull the graft into the knee, and then we put the screws in and hold it in place. So here's pulling the graft, and we take these stitches out afterwards. So here's the graft going in, and here's the bone part of it. So here's the bone, and we mark where the edge of the bone is, and here's the new ligament right here. And then we slip a wire between the bone and the tunnel, and then we put our screw in. And this is this little device just to push the graft up right where we want it. And then we slide the screw over this wire. And this is one of the bio screws. So this is a dissolvable screw. And so we want to thread it in all the way. And we have to, because these screws are a little bit fragile, they're very strong, but they're a little bit fragile, we actually have to pre-tap them. So we have to use a metal device that makes the threads, and then we put the screw over. And then that screw won't show up on an x-ray, it won't go off on an airline detector, and hopefully you'll never see it again because the patient will never need surgery again. And so there's the screw, there's the new ligament, and then we put another screw on in the tibia in a similar fashion, and here's the completed reconstruction. And here's the PCL, here's the ACL. And so we always want to go into full extension to make sure that there's enough space here to achieve full extension. If not, if you can't achieve full extension here in surgery, then the therapist will never be able to get it. So, and if I can achieve full extension in the operating room, then if we can't get full extension afterwards, then I blame the therapist. It's not my fault. So the surgery usually takes between 45 minutes to an hour, 45 minutes, depending on what graft you use and what other pathology is there. Usually we try to make fairly small incisions. The immediate post-operative treatment, has anybody heard of or still their surgeons using pain pumps? Inside the knee, inside the shoulder, they've kind of gotten a bad reputation. The lawyers love them, but there have been some studies to show, especially in the shoulder, we haven't really seen it in the knee, that it can damage some of the cartilage cells. So most of the doctors have gotten away from using pain pumps. You can inject the knee a little bit with some Novocaine afterwards. That helps pain relief. We give them narcotic medication, anti-inflammatory medication. We usually use some type of cold compressive device and usually use some brace in the immediate post-operative period. I instruct them immediately to start home exercises, and usually we have the therapist in the hospital instruct them on 5 exercises to perform, because we want to get their quads moving right away, we want the knee to get moving right away, and we want them to put some weight on it right away so that they don't sit home and do nothing for the first week or so. You can use CPM machines, but there have been studies to show that there's really no proven benefit from using CPM machines. So a patient doing their home exercises for the first week or so is just as beneficial as using a CPM machine, and the CPM machines usually cost about $30 a day. In therapy, there have been studies to show that the anterior knee pain that patients can experience after anterior cruciate ligament reconstruction can be due to poor rehab technique rather than the graft choice that you use. So some of the problems that people get with a patellar tendon graft may not be from the graft itself, but maybe from actually the therapy. Too aggressive therapy can lead to laxity, so they need to restore the motion, need to have quad strength and hamstring strength. Usually we can divide therapy into 3 phases. First is 0 to 6, 6 to 12, and 12 to 24 weeks. The first phase is that the patient wants to minimize the swelling. They want to regain full motion. They want to be able to walk without crutches, without a brace, and they want to have a normal gait pattern. Second phase, which is usually about 6 to 12 weeks, is they need to do static strengthening, core strengthening. But in order to get to phase 2, you have to have a normal range of motion. If you haven't developed a normal range of motion, you'll never get to phase 2. So some people, even at 12 weeks, won't have a normal range of motion, so then they can't progress to the next phase. So I get the question all the time, when will they be ready for this? When will they be ready for this? It's been this many weeks, why aren't they ready? Well, it's kind of dependent on the patient. The patient has to progress to the next level, and it's not sometimes a week. You can't determine it by days or weeks. You have to determine it by how the patient is actually progressing. And then the third phase, which is 12 to 24 weeks, you need a stable knee. They need no swelling, minimal quad atrophy. They can begin jumping, balancing, doing rhythmic exercises. Then they can do job-specific activities, and then they can return to work. So on ACL rehab, some of the newer studies have showed that muscle strength may not normalize for 6 to 24 months. And they did a big study on NFL football players, and they found out that it was at least 12 months before they get their strength back. So when we go back to Derrick Rose, he may not get his strength back, even though he has a trainer working with him, 6, 7 days a week. He's going to start therapy right away. He may not get his strength back for up to 24 months. So that's why they were talking about potentially being a year or 18 months till he returns. So then the question is, can our workers get back to full strength with 24 visits of therapy, which is 2 months of therapy? Some may not. The maximum graft strength may not occur for up to 18 months. So I think there is a risk for up to 18 months that you could re-injure that graft or re-damage the graft. It all depends on the patient's activity level. So if you don't have your strength for 6 to 24 months, you don't have graft strength for up to 18 months. That's why some of the people have to slow down a little bit, or they won't be able to return to their full activities. Or some patients, we tell them it may be a year, maybe 18 months, but they are safe to return back to their activities, but they may not get the maximum benefit for up to 18 months. And the other concept I touched basically briefly on this is we need to change from a time-based progression to a progression-based timing for return. So what that means is we can't say, okay, at 3 weeks you're going to be doing this, and then I want you to go to this phase at 4 weeks. It has to be a progression where they have to have satisfied the full motion, the full strength before they can go to the next phase. So that's why it's very important to have communication with your therapist to say what phase they're at. Because we know they may be 2 months from their ACL, but if you don't have notes to document that they've passed through this phase, we can't really get them to the next phase. Does that make sense? So my pet peeve is I get a note from a therapist, but it's a month old, and the therapist says, well, I don't write notes I only write notes every 6 weeks. Well, that doesn't help me because I don't know what you've been doing with the patient. I don't know how they've progressed. Oh, they're doing fine. Well, that doesn't mean anything. So for hamstrings or allografts, you may have to slow the rehab. So if you have a patient who has an ACL but had a hamstring or allograft, it may slow down compared to a patellar tendon. Delaying rehab can delay return to activities, and the number of PT visits is going to depend on their progression. Some patients, as long as they're progressing and the progression is kind of a linear fashion, then we continue with their PT visits. If they've plateaued or they're just not making progression, then we have to think, is there something else going on here that we have to stop and not just keep doing physical therapy over and over. Functional bracing, so after you've done an ACL reconstruction, what's the use of functional bracing? It's questionable, but most patients, if they have a hard job, they prefer it because it gives them a sense of stability. It gives them a sense that they have some assurance that they won't re-injure their knee. And then more recent studies have shown fewer than 60% can return to their pre-injury level. So, and that's sports, that's work. They just cannot, no matter how good the surgeon is, no matter how good the rehab is, only 60% return to where they were. 10 to 30% will have residual pain. So when the patient says, I'm not going to go back to work till I'm 100% and I have no pain, again, it's just not going to happen. So return to work. Again, it depends on their job, depends on progression. These are the AMA guidelines, and for very heavy, here we have sedentary all the way down to very heavy. Very heavy, it's up to a maximum of 140 days, and that may be, you know, a little bit low. It may, because that's only about 4.5, not even 5 months. And some patients, depending on their job, may not be able to get there. They may just not have the strength, and we know they may not have the strength until up to a year. Now, what are some of the complications? You can get patellar fractures, you can get infection, you can get patellar tendon ruptures, you can get loss of motion, you can re-tear. But there have been studies that show that the rate of complication increases with lower volume surgeons. So what that means is people who do not do very many ACL reconstructions usually have higher complication rates. One of the complication rates is loss of motion, and that's probably the number one problem is loss of motion. The patient just does not get their extension or does not get their flexion. And sometimes that will lead to patellofemoral pain, that will lead to abnormal gait, that can lead to arthritis. And there's many causes of that. One is a non-anatomic graft placement. So basically the surgeon put the graft in the wrong place. And like I said before, you can only be 2 or 3 millimeters off. And if they put it in the wrong place, now this one is just too far forward. If they put it in the wrong place, they'll never get their motion back. It just won't happen. Sometimes there can be an infection. Fortunately, that's very rare. Sometimes they'll immobilize the patient too long and they'll have a difficulty getting their motion back. Sometimes PT will be delayed for some reason, or they'll get inadequate therapy, or they can develop arthrofibrosis. And if they develop arthrofibrosis, what that is we kind of talked about it. It's an acute inflammatory condition that can occur after this type of surgery, and their knee just stiffens. And there's nothing the therapist can do. They just can't get the motion back. And it's usually intra-articular adhesions. And what you have to do is you usually have to wait until the acute inflammatory phase kind of resolves, and that will take about 3 months. So if you have a patient who had knee surgery who develops arthrofibrosis, if you try and operate on them too soon, they'll just get more adhesions. So usually you wait till the adhesions are mature. You do a manipulation. Sometimes you do a debridement. You place them in a dropout cast if they've had problems with extension, or you get a dynamic splint, such as a Dynasplint, to work on flexion. And also that's an indication for possibly a CPM machine, and also they're going to need therapy afterwards. Failures, they occur 10 to 15% of the time, and that can be recurrence of symptoms. It can be due to technique. 88% of failures are due to putting the tunnels in the wrong place. For example, if this tunnel is too far forward, and that one is going to fail. Failure of the graft to heal, or they can have a traumatic episode. Nothing can be wrong with the surgery. The surgery could have gone well. They could just tear it again at a later date. I just wanted to mention a couple of this is a failed reconstruction that I had about a week or so ago. And this is the patient's graft. And this is, I'm pointing here where the other doctor put the graft in. So the graft was right here, and you can see this is where the graft should be. So we knew just by looking at it, it was going to fail, and because the graft was placed just too far forward. And so this was a 30-year-old police officer who had constant instability, so we went in and revised it. This is another one I saw recently. This was actually a gentleman who injured his knee at work, and he went to Mexico because his family lived in Mexico. He had the reconstruction done in Mexico. And this graft, when they put it in too straight up and down. And so remember when we talked about the top, how it can spin? Well, that's what happened to him. He spun, and this is the part of his meniscus. This is a bucket handle tear of his meniscus. So he tore the whole part of his meniscus. And because his knee twisted, it tore off the meniscus and pulled it forward in his knee. And so he had a bucket handle tear. So we repaired the tear. Ultimately, it's going to keep happening until he undergoes a revision, but he doesn't want to undergo a revision of the ACL. So the keys to success, you need an experienced surgeon. You have to have realistic expectations for the patient and everyone involved. You have to have a motivated patient. If they're not going to do your therapy, if they're not motivated, they're not going to have a good result. And you need communication. This was in the Wall Street Journal on Valentine's Day. I don't know if you can read it. You probably can't read it, but they were talking about ACL reconstructions, and basically said there's a big learning curve with ACL reconstructions, and they said ACL surgery, while routine, is fairly complex, and the potential for pitfalls is very high. So even in the press, in the Wall Street Journal, they know that there are potentially be a number of complications from ACL surgery. And finally, I want to talk about cost reduction. You know, how can you minimize the cost of this? Well, first of all, you want to minimize the complications. So a patient who doesn't have any complications is going to minimize the cost. CPM machine, you have to think twice whether or not it's really useful. If a patient does his own exercises, you really don't need a CPM machine. You have to educate the patient about expectations and what they should expect before the surgery, after the surgery, and at each step, so that they're not tentative, or they will kind of go through the therapy and progress as you want them to. And allografts, you have to be a little bit wary of surgeons. Some surgeons just use allografts 100% of the time on every patient because that's what they do. And you have to be wary because allografts are kind of expensive, and not every patient needs an allograft. Also, you want to be able to minimize their time off work. So you want to try and avoid approval delays. Sometimes it's unavoidable, but if we can minimize those, that helps. And that just involves communication, you know, with the therapist, the employer, the nurse, the surgeon, the patient. Also, physical therapy, what we've run into recently is after an ACL, they'll give us 8 visits of therapy, and then we have to get another approval for 8 more visits, and sometimes it takes 2 to 3 weeks to get that approval. So then the patient's sitting there, he's not getting any better. And then what's going on is you've had 2 or 3 months have gone by, you've only had 15 visits of therapy, and so the patient's not getting better as quickly as they should. And in one study, 62% of the work comp time was spent waiting for approval for therapy. Now, another thing, the number one way to get cost reduction is to get good results. And I know it's kind of hard to see here, but this is out of the disability guidelines, the new disability guidelines. I think you heard a lecture about this before. And if you perform anterior cruciate ligament reconstruction and you have no instability, then all of a sudden they're going to have no disability. And their impairment is going to be very small, or nothing for the ACL. Now, if you get to the point where you have moderate laxity, then you can get to the point where they have up to 7% of full body impairment. And that ultimately is going to cost more money, because if they go with a settlement, that'll translate to more dollars. So ultimately, you want to get them to this area where they cannot derive a big settlement. So in summary, the ACL is the main stabilizer of the knee. Injuries are usually non-contact. Many can be treated without surgery. Operative treatment involves kind of many different decisions as far as where to place the tunnels, which graft to use, things like that. The experience of the surgery is important. Communication is paramount. That's very important. Therapy should be tailored to the individual patient, and good outcomes can save money. Thank you.